Hi, my name is Alberto Lorenzatti from Cordoba, Argentina. I would like to thank the organizer for inviting me to this excellent symposium about cardiology, diabetes, and nephrology at the limits. In the next several minutes, I will address new strategies to mitigate the residual vascular risk in diabetes. These are my potential conflicts of interest regarding with this presentation. This is the agenda that I would like to comment with you. The prevalence of cardiometabolic risk factors in Latin America, diabetic dyslipidemia as the perfect storm, remnant particles, sleeping with the enemy, I would say, managing dyslipidemia to reduce cardiovascular risk, targeting triglycerides to reduce residual risk, some comments on emerging therapies, and concluding remarks. Type 2 diabetes is a growing health concern across the world, and cardiovascular disease remains as the major cause of increased mortality in this patient population. You can see in a cohort of near 2 million patients, stable angina and stable angina, non-fatal MI, heart failure, ischemic stroke. The initial presentation is more or less 50% increases regarding no diabetic population. And pay attention, the initial presentation of peripheral arterial disease is near 3 times more than people without diabetes. What about Latin America? The last big epidemiological study, I mean the InterHeart study in Latin American version, showed us that obesity has become a major health problem in Latin America, with abdominal obesity being a population attributable risk of about 50%. And dyslipidemia, assessed by the relationship between ApoB and ApoA1, is the second population attributable risk in the region of about 40%. The pandemic has increased the cardiometabolic risk factors as a consequence of the pandemic in the region. This is a study that we published recently in more than 4,000 patients in more or less 10 countries all over Latin America. We found more than 70% of hypertensive patients, near 40% patients with dyslipidemia, and more than 20% diabetic patients among this pool of cardiometabolic patients. But the bad thing is that the lack of regular physical activity was present in about 40% of the patients, and less than 100 minutes per week was the reality in near half of these patients. The regular alcohol intake was present in half of this cohort. And finally, the everyday consumption of fruits and vegetables was quite low, less than a third of these patients. But the extremely bad thing, apart of the more than 60% of reducing the regular physical activity, was that a third of our patients had access problems in terms of getting their medication for dyslipidemia, hypertension, etc. These were the problems that, as consequence of the pandemic in our region, or the worsening of all factors related to cardiometabolic risk factor. We published recently a Latin American consensus on management of residual cardiometabolic risk. In this panel of experts have participated some colleagues from from Brazil. This is a central illustration of the article, and you can see the 5 main risk factors that we have to address in order to control the cardiometabolic risk factor in our patients: inflammation, hypertension, glucose metabolism, the prothrombotic risk factor, and atherogenic dyslipidemia. We will focus on lipids in this particular presentation. What about diabetic dyslipidemia? I would like to call the perfect storm. Why? You can see in the screen several different lipoproteins, HDL and LDL are the big cholesterol transporters. HDL is anti-atherogenic, you know. LDL is the paradigm of atherogenic lipoprotein, but we have several lipoproteins containing triglycerides that are potentially pro-atherogenic. I mean chylomicron and its remnants, VLDL and its remnants, and IDL as a source, as a lipoprotein that have the capability to produce atherogenesis. What about the changes in the dyslipidemia in the diabetic patient? Okay, there are quantitative changes, qualitative changes, and metabolic kinetic changes. Regarding chylomicrons, more production, less catabolism. Regarding VLDL, the same, more production, lower catabolism. Regarding LDL, there are a very strong predominance of small and dense LDL particles and enriched with triglycerides. Regarding HDL, also enriched with triglycerides, the catabolism is higher, and there is a condition that shows a constant low HDL as a way of presentation. In this cartoon, from our recent publication regarding the atherogenic dyslipidemia, you can see in the diabetic patient there are more production of VLDL. VLDL interchange triglycerides by cholesterol with LDL, also with HDL. Both kind of lipoproteins are enriched with triglycerides. And finally, the VLDL remnant, which is enriched with cholesterol, is more pro-atherogenic, the perfect storm. Here you have a very interesting and recent publication. You can see the curves corresponded to event-free survival in black, diabetic patients, in blue, pre-diabetic patients, and in red, normal glucose metabolism patients. But in this cohort of more than 3,000 patients, followed by 6 years, when the authors include the presence of atherogenic dyslipidemia, all conditions that show with atherogenic dyslipidemia literally show the same less event-free survival. Another example from a big cohort near 28,000 patients, you can see the patient with high triglycerides between 200 and 500 in comparison with the patient with less than 150 milligrams per deciliter. There were a 30% increase in non-fatal MI, 23% increase in non-fatal stroke, and all patients were well controlled regarding LDL using the statins. What about remnant particles? Sleeping with the enemy? Why? Because the chylomicrons represent the exogenous triglyceride pathway, VLDL, the endogenous one, and both kind of particles undergo lipolysis through the lipoprotein lipase. The consequence are remnant lipoproteins that have the ability to be pro-atherogenic. In a clinical practice, we can calculate the presence of this kind of particles subtracting from the total cholesterol, the HDL cholesterol, which means non-HDL, and a further subtraction of the number of LDL, and we have a number which should be less than 30 milligrams per deciliter. It's not, in fact, it's not well standardized, but ideally less than 30, less than 25 milligrams per deciliter is desirable. Here in this excellent cartoon, you can see that chylomicron remnants and VLDL remnants are pro-atherogenic, are small enough that they are able to introduce in the sub with the proteins, promoting focal inflammation and interacting with bone cells. In other words, not only LDL is pro-atherogenic, these remnant particles that contains ApoB and contains also cholesterol are atherogenic phenomenon. Here you have it's an elegant study with near 7,000 patients. The BMI on average was 30, diabetic patient, and followed by near 5 years. You can see the Kaplan-Meier curves in red, corresponding to patients with more than 30 milligrams per deciliter of cholesterol remnants, with LDL more than 100, and the blue one corresponds to patients with more than 30 milligrams per deciliter. We are talking about basal levels, and LDL less than this. There were a more incremental incidence of cardiovascular events. In the same way, a recent very excellent study with data from ARIC, MESA, and cardiac study in a cohort of about 17,000 patients. The author divided in cholesterol remnant, basal cholesterol remnant more than 24 or less than 24, and you can see patients with more than this cutting point of 24 and LDL less than 130 and more than 24 milligrams per deciliter and LDL more than 130, they showed 50 and 65% increase in the risk of event respectively. Again, two examples of this kind of remnant lipoprotein that counts in terms of cardiovascular risk. What about the managing of the lipidemia for reducing cardiovascular risk? This algorithm is part of the Latin American consensus. We will focus on very high risk patients. The target proposed is less than 55 milligrams per deciliter. If the patient do not achieve this target, the introduction of PCSK9 inhibitor or ezetimibe is recommended. If yes, the patient is on target, but triglycerides are over 200 milligrams per deciliter, or non-HDL is also elevated, the recommendation is the addition of omega-3 fatty acid, EPA, or fibrates. We have a very interesting armamentarium, therapeutic armamentarium now in order to control LDL and other lipoproteins. You can see, for example, the most potent combination are a PCSK9 plus statin, high intensity, and the triple combination of PCSK9 plus high statin, intensity statin plus ezetimibe. But in clinical practice, we have to pay attention on the doses. This is a very interesting work from a patient in TNT study, individuals who have had remnant cholesterol from 24 to 30, from 30 to 40, and from more than 40, they show a reduction, risk reduction, very significant in favor of the utilization of high intensity statin. I mean, atorva 80 in comparison with atorvastatin 10 milligrams. The second line drug recommended for the guidelines is ezetimibe. Ezetimibe has shown in the improved study very good results in diabetic patients. Finally, the PCSK9 inhibitor are showing very good results, not only in terms of risk reduction. You are familiar with the Fourier study and the Odyssey study. This is a study that we published recently, showing the data from near 1,000 diabetic patients treated with statins, and on top of a statin, evolocumab versus placebo. You can see the profound reduction on LDL cholesterol of about 70%. In the same cohort, we added data from other study, the Banten study. In total, there were 1,400 patients, diabetic patients, treated with a statin, and the intervention was evolocumab versus placebo. We divided this cohort in patients with atherogenic dyslipidemia and patients with without atherogenic dyslipidemia. In all patient population, there were a reduction of LDL of about between 60 and 70% in favor of the PCSK9 inhibition, and also the reduction on non-HDL was also verified of about 60%. In a very interesting way, all patients, irrespective of the presence of the atherogenic dyslipidemia or not, the vast majority of patients achieve to the targets recommended for the European guideline, that is less than 55 milligrams per deciliter, plus a reduction of 50% in the LDL levels in comparison with the baseline levels. Here you have the same analysis with non-HDL cholesterol. The vast majority of the patients achieved to the target for very high risk patients, and in the same way, the target proposed in terms of ApoB reduction for the high risk patient for the European guidelines is achieved in a very easy way with the utilization of the PCSK9 inhibitor. I am presenting an additional data, the reduction in VLDL and the reduction in remnant cholesterol also the same cohort of patients, all diabetics, or all were treated with a statin, and the intervention was evolocumab versus placebo. You can see between 16 and 20% of reduction in VLDL in patients with atherogenic dyslipidemia, and the reduction between 30 and 35% of remnant cholesterol, also in patients with atherogenic dyslipidemia. The effect in patients without atherogenic dyslipidemia was not significant. Please do not forget the lifestyle changes. This is important to talk with our patients regarding to encourage the adherence to lifestyle changes. It's critical in atherogenic dyslipidemia, and is critical in this diabetic patient. What about targeting triglycerides in order to further reduce the residual risk? The guidelines, the European guidelines recommend there is no target for triglycerides, but in patients with persistently elevated triglycerides between 135 and 500, these guidelines recommend the addition of omega-3 fatty acids, especially EPA. Here you have a list of intervention, the common intervention that have some effects on triglyceride level. For example, statins are the first line therapy. Their impact on triglyceride reduction is not more than 20%. Fibrates are the most potent drug in management triglycerides, reducing up to 50%, but the potency to decrease overall cardiovascular risk is modest. What about omega-3? EPA demonstrated 25 relative risk reduction in both primary and secondary prevention, but increased incident atrial fibrillation. Ezetimibe just have a slight decrease in TG levels. The data with the PCSK9 inhibitor is controversial. Volanesersen is a new drug, new generation of oligonucleotide antisense drug, anti-ApoC3, that can reduce TG levels in a very important and strong manner, dose-dependent manner, up to 80%. Inclisiran is majorly effective in reducing LDL, and there are a couple of anti-diabetic formulations, GLP-1 receptor agonists, that can reduce ApoB/40A and apparently decreases the production of atherogenic remnant in diabetic patients. And finally, the SGLT2 inhibitors can decrease fasting and postprandial triglyceride concentration. Here you have the result of the reduced trial, but lately the results of the strength with the combination of EPA and DHA omega-3 fatty acid was absolutely neutral, and the trial was stopped early for this reason. Recently, and I think it is important, has been published a big meta-analysis including near 150,000 patients from 38 studies. The result was a 13% significant reduction in non-fatal MI, 7% significant reduction in cardiovascular mortality. But the bad news is that, for example, omega-3 increases the incident at atrial fibrillation in and particularly EPA increased the risk of bleeding in near 50% and the incidence of atrial fibrillation in 35%. The controversy is still running. There are some doctors in favor, some doctors against the utilization of omega-3, but probably more investigations are needed in this regard. What about new therapies? There are new targets in this lipidemia, the angiopoietin like protein 3 and the ApoC3. There are some products in development, the volanesorsen I mentioned before, the evinacumab, and others that target the angiopoietin like protein 3. And this targeting this protein, you can reduce not only VLDL, also LDL. This is a very interesting approach. And I have mentioned that volanesorsen reduces triglycerides from the chylomicrons, for example, in a very potent way. Finally, my concluding remarks, atherogenic dyslipidemia is a very prevalent condition in our population in Latin America. It involves a profound qualitative, quantitative, and kinetic metabolic alteration in the lipid metabolism. Lifestyle changes are fundamental. LDL cholesterol control is the priority, with the statin in the adequate doses according to the patient risk. Ezetimibe or the inhibition of PCSK9 can be an alternative when the LDL goals are not reached. Fibrates or omega-3 fatty acids should be considered when TGs remains persistently elevated. And finally, new drugs with novel therapeutic targets are under development. Obrigado. Many thanks.